Good afternoon, everyone. So now my next topic of the video is gout. Now I'm going to discuss with you gout. And before I start my video, I want to request you that if you like this video and if it is helpful and useful to you, kindly subscribe to our YouTube channel, that is Dr. Nitika's Pharmacology Discussion. So now I'm going to discuss with you gout and the treatment of gout with you. So what is gout? It is the metabolic disease in which there is increase in the uric acid levels in the body, and its serum uric acid rises more than 7 milligram percent in males and 6% milligram percent in females. Means there is increase in uric acid levels in the blood, which leads to hyperuricemia, which is known as gout. And basically it manifests as arthritis. There is acute arthritis, means pain and inflammation of the joints is there, and there is deposition of uric crystals in the synovial tissue of joints. There is deposition of uric crystals in the synovial tissue of joints. This is the involvement of soft joints, small joints. Basically the gout is basically seen in, first of all, metatarsophalangeal joints. It may be seen in wrist, in the joints of wrist, ankle, knee, shoulder, and in fingers and toes. Basically, there is erosions, there is articular damage. Bony erosions will be seen in 45%, and they take 6 years to develop. The bony erosions will be there. These articular damage and bony erosions of the joints will take place in the gout. Now, what is the pathophysiology of the gout or hyperuricemia is? There is increased uric acid levels in the body that will lead to deposition of the uric crystals, which is in the acute gout, there is deposition of uric crystals in the joints like kidney, joints, and subcutaneous tissues as tophi. And in chronic diseases, there is subcutaneous tophi formed in the chronic gout, and that will initiate the inflammatory process. There will be inflammation, and when there is inflammation, there will be infiltration of the granulocytes, and there will be infiltration of the uric crystals. Granulocyte will be infiltrated, that will engulf the uric crystals by phagocytosis. There will be phagocytosis of the joints of the synovial tissue or the joint tissue, and there will be oxygen free radicals will be generated which will damage the tissue, and there will be release of the lysosomal enzymes and glycoproteins which will cause inflammation and pain. And when there is a release of the lysosomal enzymes, there will be lactic acid production in the synovial tissues. So there will be lowering of pH that will lead to deposition of uric crystals in the joint, which will lead to development of gout. Causes of acute gout are the increased alcohol intake, rich diet in protein, purines, and kidney disease. And causes of chronic gout can be genetic defects like leukemias, lymphomas, and other diseases like genetic diseases, and renal deficiencies can lead to chronic gout. Or there is excessive synthesis of uric acid in patients receiving radiotherapy or radiation in the cancer chemotherapy. Treatment goals are that we have to terminate the attack of gout. We have to reduce the pain and inflammation. We have to prevent the future attacks. And we have to prevent the complications like renal stones, tophi, destructive arthropathy. The arthropathy means joint destruction can be there. Subcutaneous tophi will be formed in chronic gout, or renal stones may develop. So all these complications has to be prevented. That is the treatment goal. Non-pharmacological is that treatment is that we have to immobilize the joint, we have to apply the ice packs, and we have to there is abstinence of alcohol. Means we have to avoid the alcohol consumption. Can lead to increased uric crystals, uric levels by increasing uric acid production. Means alcohol can lead to increased uric levels and leading to increase in uric acid production. So there is abstinence of alcohol should be there. And dietary modifications is that we have to decrease the protein and protein rich diet like meat and seafood. Based on severity of the disease, acute gout, we have the colchicine, which inhibits the release of the inflammatory mediators and release of the neutrophils and macrophages in the synovial tissue, and inhibit the release of lysosomal enzymes, and also it inhibit the release of the glycoprotein in the joints, which causes pain and inflammation. Prednisolone and NSAIDs are known to reduce the pain and inflammation. And chronic gout, allopurinol is a uric acid synthesis inhibitor. Probane acid and sulfenpirazone, these increases the uric acid excretion in the body from the renal tubules. NSAIDs, naproxen, indomethacin, Sulindac are FDA approved for acute gout. For the acute gout, these are the COX-2 inhibitors, and these drugs are very much approved for the treatment of acute gout, in which there is pain and inflammation, and there is deposition of the uric crystals in the joints, leading to pain and inflammation. In the chronic gout, there is no deposition of uric crystals in the joints, but the levels of uric acid are more. So subcutaneous tissues, they develop tophi, and there will be destruction of the joints. Mechanism of action of drugs used in gout is that the purines, which are obtained from the RNA and DNA, they get converted to as hypoxanthine by action of xanthine oxidase, and xanthine gets converted to hypoxanthine gets converted to xanthine again by the xanthine oxidase, and xanthine gets converted to uric acid by the xanthine oxidase. So this xanthine oxidase is inhibited, which is the non-competitive inhibitor of the uric acid, is this non-competitive inhibitor of the xanthine oxidase is the uric acid. So this xanthine oxidase has to be blocked. Its action has to be blocked. So competitive inhibitor of the xanthine oxidase is the allopurinol, which inhibits the xanthine oxidase. So no formation of uric acid takes place, so levels of uric acid in the body decreases. Allopurinol, xanthine gets converted to has uric acid, and there is the uric acid, it is a urinary excretion is there, or synovial deposition is there. The increased urinary excretion is by the probane acid and sulfenpirazone, and the colchicine, it inhibits the phagocytosis, and there is a reduced synovial deposition of the uric crystals. And since it reduces the inflammation, so this will lead to decreased pain and inflammation in the joints. Non-steroidal anti-inflammatory reduce the pain and inflammation. Colchicine reduces the phagocytosis of the uric crystals of the synovial joint, phagocytosis, so uric crystals does not develop. Inhibit the glycoprotein, inhibit the infiltration of macrophages and granulocytes in the synovial joints. So reduced uric crystals formation. Allopurinol, half-life is 2 hours, but its major metabolite is alloxanthine, which is the acts on the non-competitively and is long-acting with half-life of 24 hours. Means alloxanthine, it is the non-competitive inhibitor of xanthine oxidase, and it acts for the period of 24 hours. Reduces concentration of insoluble urate and uric acid, but increases concentration of soluble xanthine and hypoxanthine, because they inhibit the xanthine oxidase, so levels of xanthine and hypoxanthine will increase, but levels of the uric acid in the body will decrease. Means they inhibit the formation of uric acid. So deposition of uric crystals is reversed, and renal stone formation is inhibited. Ineffective for acute gout, but drug of choice for long-term treatment of chronic gout. It is ineffective for acute gout, in which there is deposition of uric crystals in the joints. In acute gout, it is ineffective, but for the chronic gout, it is the drug of choice, allopurinol. Pharmacokinetics is it is well absorbed orally, not bound to plasma proteins. It is used for chronic gout and also for Kala-Azar, because it inhibits the it inhibits the leishmania growth also. Adverse drug reactions is hypersensitivity reactions, fever, rashes, malaise, muscle pain, gastric irritation, nausea, headache, dizziness, hepatic renal failure, and Stephen-Johnson syndrome. These are the various adverse effects of the allopurinol. Precautions: liberal use of fluid along with this therapy. We have to use the liberal, a lot of fluid has to be taken along with this therapy, and contraindicated in hypertensive patients, pregnancy and lactation. Use should be cautiously in the elderly, children, liver and renal diseases. Febuxostat is the another xanthine oxidase inhibitor, and it is FDA approved for chronic gout. More selective than allopurinol, extensively metabolized by liver, and little dependence on renal excretion. As with allopurinol, prophylactic treatment with colchicine and NSAIDs should start from beginning to avoid gouty flares. This we have to do the prophylactic treatment with the colchicine and NSAIDs should start from beginning to avoid the gouty flares and to increase the risk of gout in the patients. And generally well tolerated. Liver toxicity, nausea, diarrhea, headache may occur. Colchicine, it is the alkaloid obtained from Colchium autumnale. For acute gout is preferred, and it inhibits the neutrophil migration to urate deposited sites. It decreases the phagocytosis of urate. Decreases the phagocytosis of urate, inhibits the subsequent events of inflammation. Means it inhibits the inflammation events, inhibits the neutrophil migration, inhibits the phagocytosis, and inhibits the lysosomal activity, inhibits the release of glycoprotein, which cause the urate crystal deposition in the joints. Acute side effects: abdominal pain, vomiting, diarrhea. These are the acute side effects. Chronic side effects can be myopathy, and there can be renal damage, bone marrow depression, loss of hair, peripheral neuropathy. And since they suppress the pain and inflammation, aspirin is avoided because it causes uric acid retention, which it decreases the uric acid excretion. It causes hyperuricemia, so aspirin is a drug which is avoided. Indomethacin, Sulindac, naproxen, piroxicam, diclofenac are the other NSAIDs which reduces the pain and inflammation. These are important because many patients cannot tolerate the colchicine, which is used as the drug in the acute gout. Corticosteroids, these are glucocorticoids. They severe symptomatic relief. Oral prednisone for 1 to 2 days with tapering of dose over 7 to 10 days. Intraarticular injections of triamcinolone acetonide can be given. Propionic acid, it is the drug which inhibits the active renal tubular transport of weak organic acids, including penicillin and uric acid, it is bidirectional. It inhibits the renal tubular secretion of the uric acid, excretion of the uric acid and the penicillin. So increases the uh, uh, excretion of uric acid and thus decreases the level of uric crystal in the body. Is largely reabsorbed by active transport, which is inhibited by propionic acid. Uric acid is largely reabsorbed by the active transport and which is inhibited by propionic acid. Hence, net effect is more of uric acid is secreted as reducing the blood levels of the uric acid. It has the uricose-uric effect. Propionic acid and penicillin is that propionic acid inhibits the excretion of the penicillin in tubular excretion of the penicillin. So there will be more levels of penicillin in the body. Propionic acid and thiazides is that the thiazides increase the uric acid, serum uric acid by decreasing amount of uric acid excreted by organic acid. Secretory system being insoluble gets deposited in joints. Means thiazides, they increase the serum uric acid by decreasing the amount of uric acid excreted. So they will decrease the uric acid excreted by organic acid secretory system. So the levels of uric acid will increase in the body. They will be getting deposited in the joints. Full-blown acute attack of the gout may be precipitated, and there will be full-blown acute attack of gout may be precipitated. American College of Rheumatology guidelines, non-pharmacological treatment of the gout is that it is weight control, healthy diet, exercise, smoking cessation, and hydration. Pharmacological first-line treatment of chronic gout is allopurinol and febuxostat. Propionic acid can be used as an alternative. Start urate-lowering therapy during acute attack and monitor every 2 to 3 weeks. Serum uric acid should be less than 6 milligram percent in females and less than 7 milligram percent in males. Thank you. That's all for gout. I hope you understood this lecture. And if you understood this lecture, kindly subscribe to my YouTube channel. That is Dr. Nitika Hans Pharmacology Discussion. Thank you. Be safe, be healthy, be happy, stay blessed. Thank you.